All right, in this video, we're going to be talking about a couple things. We're going to be talking about the idea of informed consent, and we'll be talking about how to make decisions on behalf of patients who are incapacitated or who lack competency, such as patients who are in a coma. Now, there are many cases in which patients are unable to choose treatment for themselves. For example, if a patient is in a persistent vegetative state or in a coma. Also, young children can't choose for themselves. They need somebody else to choose for them. So in cases in which somebody is, say, in a persistent vegetative state or who lacks capacity, how do we choose for them? And there are different principles that tell us how to choose for them. Uh, One principle is called the best interest standard, and it basically says that we should choose whatever is in their best interest. There's another principle called the substituted judgment principle, and that takes precedent over the best interest standard. The substituted judgment principle basically says that you should choose for the patient what they would choose if they were competent and able to make choices. And that principle is important because it respects that patient's autonomy. Now, a further question about choosing for patients is who should choose for the patient. Now, usually, well, not usually, but ideally what would happen is there would be an advance directive, and in that advance directive, the patient would specify what to do in certain circumstances if they lacked decision-making capacity. But often what happens is they don't have an advance directive, and then it's up in the air, well, who should decide? Usually a surrogate decides on their behalf, and often the surrogate is somebody who's close, a family member or somebody like that, and that's important because you want to find somebody who really knows the patient and can make a good judgment on what the patient themselves would want in that situation if they were awake and competent or whatever. Um, One question that I'll just sort of throw out there is perhaps an algorithm, an artificial intelligence, could in the future make decisions on behalf of patients by taking in data such as social media data and using that data to sort of predict the patient's preferences. There's already studies that have been done that show that algorithms can predict pretty well with enough data a person's preference and that person's personality. I'm just going to throw that out there. Another ethical issue that's related to this regarding patients who are in a coma or persistent vegetative state are standards of brain death. We've touched on this before, so I'll touch on this briefly in this lecture. So the question is, when should a person be considered dead? Now, this ethically is important for a number of reasons. One reason is because it can determine whether or not their organs are harvested for other people, for organ donation. Um, so that's one reason why this question can matter ethically. Now, it's become difficult to answer this question of what counts as death due to support technology, life support technology. Back in the day, we had the whole body standard, which basically says that a person is dead when they don't wake up after a few days. But that's a dated conception of death. Since we now have life support technology, this standard doesn't really work anymore. Now, there's also something called the Harvard standard, which basically says that unawareness of external stimuli, lack of bodily movements, no spontaneous breathing, lack of reflexes, and two nearly flat EEG readings 24 hours apart, that constitutes death. Now, many people say that this standard is too strong a standard of death. So if you think that's too strong, you might like the cognitive criteria, which is basically saying that a person that can be considered dead, and so you can harvest their organs for organ donation. According to the standard, they are dead once reason, memory, agency, and self-awareness are gone, and the patient is no longer really a person, but rather just sort of just a human, or what you might call a vegetable. But this is pretty controversial. It would mean that somebody who lacks higher brain activity is dead, even though they may still have lower brain activity. The brainstem might still have some activity going on. So this is also a pretty controversial definition. And we also have the irreversibility standard of death, which basically says that death is when unconsciousness is irreversible. So if you have somebody in a persistent vegetative state who's unconscious and physicians deem that there's no going back to consciousness, it's irreversible, that's another standard. So which standard is most appropriate is a subject of debate in bioethics. Many ethical issues arise when cases are deemed futile. So we have futile cases versus non-futile cases. A futile case basically means that the physician deems that this patient will not get better. And the standard for that is pretty high. There has to be a pretty high chance that the patient will not be able to get better. And this raises many ethical questions. For example, should a relative be able to force a medical team to continue care if that team deems that patient's case futile? And some people say yes, some people say no. People that say yes would say, well, uh, a relative should be able to force a medical team to continue care because this respects the family's wishes and maybe it respects the patient. Other people say no, once it's futile, a family should not be able to force continued care. And one of the reasons is because, this is using precious medical resources that could be used somewhere else. So that's more of an issue of justice. Now, usually, I think from what I've gathered, usually what happens is if a case is deemed futile and the family wants to continue care, the healthcare team may say, okay, well, we'll continue care for maybe another week or another couple weeks, and then they give a hard deadline just to sort of appease the family. So many issues come up with regards to futile cases. All right, now we're going to switch gears a little bit and talk about informed consent. So this is a very important issue in medical ethics because a patient consenting to something is a way of respecting that patient's autonomy. What's interesting is that respecting a patient's autonomy is a relatively new phenomena in medicine. Back in, say, the 19th century, patients weren't really treated with a whole lot of respect. They weren't treated as autonomous agents. Medicine was very paternalistic. Physicians did things for the patient's own good, whether the patients liked it or not. But today, medicine has changed quite a bit, and patient autonomy is deemed as very important, and that's where we got that principle of autonomy, where you need to respect the patient's autonomy. And one way of respecting a patient's autonomy is to make sure that they consent to any kind of procedure, and that consent is informed. Now, what actually constitutes consent, or the conditions of being informed, for that consent being informed, is up for debate. So we're going to take a look at those two things: what constitutes consent and the conditions for that consent actually being informed consent. So informed consent is this: an autonomous, informed person agreeing or authorizing to submit to medical treatment. So notice that in order for somebody to consent, they have to be autonomous. So by definition, somebody who is not autonomous can't possibly consent to anything. They lack autonomy. So in order for somebody to truly consent, they have to be autonomous. What that means is that, say, a child of 5 years old, by definition, can't consent to anything because they're not autonomous. Consent just doesn't come into play at all. Or somebody who obviously is in a persistent vegetative state can't consent to anything because they are not autonomous. Now, respecting a patient's autonomy requires letting that patient voluntarily choose treatment, even if the physician disagrees with that decision. So if a patient does not consent, does not voluntarily choose a treatment, then even if the physician disagrees with that, you still have to respect the patient's decision. And that's because today, autonomy is very important. Now, informed consent may often, but not always, be good for the patient. So we can justify informed consent by the principle of beneficence, at least in cases when informed consent is good for the patient. Now, what's interesting is that sometimes informed consent may not be good for the patient. They may not consent to something that may be bad for them, but nevertheless, the principle of autonomy requires us to respect that decision. Now, actually implementing informed consent can be quite difficult, and if you're a healthcare professional, you have maybe encountered many cases where it could be difficult to actually get informed consent, and we'll talk about that in a second, what counts as informed consent. So here are the conditions for informed consent. Informed consent happens if and only if the patient is competent, so the patient has to be competent. The patient gets adequate disclosure of information, so the patient needs to get enough information for that consent to be informed. the patient actually understands the information. Now, it's up for debate um, how much they are able to understand it in order for it to be informed. The patient decides the treatment voluntarily, and obviously the patient consents to that treatment. So these are the conditions that need to be in place for it to be considered informed consent. Now, a little bit about competency. So that was the first condition. The patient has to be competent in order for them agreeing to something to be considered informed consent. So generally, a person possesses the mental competency is a person possesses the mental condition to be responsible for a decision he or she makes. So if a person is deemed incompetent, then at least in that state of incompetency, if they make a decision, they wouldn't be held accountable for it, or they wouldn't really be held responsible for it. Right? So, a 5-year-old is not, it would be considered incompetent. If a 5-year-old decides something and it results in something bad, they're not really going to be held responsible for it because they're 5 years old. They're not competent. Now, in medicine, competency, a patient is always assumed competent unless judged otherwise. It's kind of like in law, you're innocent until proven guilty. In medicine, you're assumed competent unless proven otherwise. And there can be many cases of a person being considered incompetent. Incompetency can come and go. It's not necessarily a permanent mental state. So certain cases where a patient may be deemed incompetent might be cases in which the patient has some kind of severe cognitive disability, maybe dementia or psychosis. This is an example where if a patient is in a psychotic state, they may be deemed incompetent, but that patient may come out of psychosis and come out of the psychotic state and then regain competency. So you see this kind of thing with certain mental or psychiatric conditions like schizophrenia or severe forms of bipolar disorder, etc. Sometimes alcoholism, if somebody's an alcoholic and in a certain state they may be deemed incompetent, that's up for debate. And minors are considered incompetent, to a certain degree, depending on how old they are. The younger they are, the less competent they are. And there can be some other cases as well. Now, another thing that's important when investigating competency is that being incompetent is not necessarily global. Now, in medicine, if somebody is deemed incompetent and therefore can't give consent, it's considered global. But generally speaking, incompetency can be specific to a particular aspect of life. So somebody might be incompetent in handling finances, for example, but nevertheless, they're still competent enough to give informed consent. Or I'm incompetent at most sports, but I'm competent enough sort of globally to give informed consent. So, and another thing to keep in mind is that being involuntarily institutionalized for mental illness, that doesn't necessarily imply that the patient is incompetent. Those two things can come apart. Another ethical issue that rises here is who decides if a patient is incompetent to give informed consent. Often it's the healthcare professional who makes this decision, but sometimes it has to go to court. Judges might have to make that decision depending on the case. And a question that we considered last time was, if a patient is deemed incompetent, then who decides on behalf of the patient? And if you recall, the main principle that we use to make that decision is called the principle of substituted judgment. So you decide, the surrogate decides what the patient would want. Usually this is a family member or close friend, somebody who knows the patient well. And if there is nobody like that, then there's often an ethics committee or an ethicist who might make that decision, or the physician might have to make that decision. All right, so a little bit about the conditions of competency. So here are the conditions that need to be met in order for a patient to have decision-making capacity, in order for the patient to be considered competent. The patient makes and communicates a choice regarding medical treatment. So you can see that this patient is communicating a clear choice. They're exercising their agency. second condition is that the patient appreciates the following disclosed information regarding medical care. So you can't just disclose the information, you have to see that the patient sort of gets it and grasps it and appreciates the significance of the information. So the information they need to know and appreciate is the diagnosis and the prognosis. They need to know the nature of the recommended care. They need to appreciate and know the alternative courses of care. They also need to know the risks, the benefits, and consequences of each of these alternatives to care. And then the third condition for competency is the patient makes decisions that are consistent with their values and goals. So, in other words, you have to see that the patient is acting rationally. If the patient is doing something that is clearly not in line with their own values, or is clearly not going to benefit them, they may be acting irrationally. So that's basically what number 3 is getting at. And number 4, the decision cannot be the result of delusion. Okay, so those are the conditions of competency. You can see 3 and 5 kind of go together. The patient uses logical reasoning to make a decision. Okay, so remember, a big part of informed consent is that the patient is informed. So what information does the patient need to know? This is a hard question to answer because treatments and procedures can be quite complex, and there's a depth to them, and a lot of it requires technical knowledge. So how much does the patient need to know in order for that consent to be deemed informed? So what is the standard of adequacy? So usually disclosure is adequate. It's deemed adequate if it allows the patient to weigh intelligently the risks and benefits of the choices that are available. So they need to know just enough that they can actually weigh the risks and benefits of each kind of treatment. Now there's a further question. Who makes this judgment of whether or not enough information is disclosed? Well, there's a few different standards that ethicists sort of debate over. There's the physician-based standard, which basically says physicians should choose what information is adequate. They should make that judgment. But some people say that might give too much power to physicians. It may not respect patients. So then you get the patient-based standard, which says that whatever a reasonable person would deem adequate, that's what we should disclose. That can be difficult to judge, so you might have a subjective standard. Or some people may not fit that patient-based standard, and we should still respect that patient, that actual patient. And that gets us the subjective standard, which says that disclosure should be based on the needs of the particular patient. So these are 3 different standards. Usually in practice, they're sort of combined depending on the case. Okay, so we've looked at how much information should be disclosed in order for that consent to be informed. Well, what information exactly should be disclosed? Well, there's 4 pieces of information according to the common approach. The first thing that needs to be disclosed is the nature of the procedure. Is this a test? Is it a treatment? How invasive is it? How long is this procedure going to last? Etc. The second piece of information that needs to be disclosed is how risky the procedure is. What kinds of risks are involved? How serious are the risks? How probable are the risks? Etc. The third piece of information that needs to be disclosed are the alternatives to the proposed procedure. So the physician may say, we recommend procedure X, but here are some alternatives if you don't want to do procedure X, and look at the nature of those alternatives and the risks of those alternatives. And the fourth piece of information is the expected benefit of the proposed procedure. What is the likely outcome of the procedure? So this is the information that needs to be disclosed to the patient. Now, there are a couple exceptions to disclosure when you may not need to disclose all information to the patient. The first is a patient waiver. The patient may voluntarily relinquish the right to be informed. This could happen, for example, if you've ever done 23andMe, get a genetic test done, you may relinquish your right for them to inform you of your health results for whatever reason. You may not want to know for whatever reason. Um, Another interesting exception to disclosing information is called therapeutic privilege. And this is withholding relevant information from the patient when the physician or healthcare professional believes that disclosure would likely cause too much harm. And you may want to pause this video and see if you can think of any cases in which, in order to prevent too much harm, the physician or healthcare professional should withhold information. So one perhaps interesting case in which a psychiatrist might want to withhold certain information, or a psychologist, is if they believe a patient has a certain psychiatric syndrome or mental disorder. Um, but this disorder, just call it X. But let's say this disorder is highly stigmatized in society. There are many psychiatric disorders that are stigmatized in society, such as certain, like maybe certain kinds of sociopathy, or clinical depression has been stigmatized, not so much anymore. And there's others that you could probably think of. But let's say that this disorder is highly stigmatized, and the psychiatrist doesn't want to tell the patient they think they have this disorder, because if they did, because it's stigmatized, may actually cause the patient a lot of mental distress that could exacerbate their condition. So that might be an example of something that the physician or psychiatrist should withhold. But that's up for debate. That's something you could write your paper on. So a couple more issues with consent. Consent must be voluntary. This should be pretty obvious. Consent is not voluntary if it is coerced or influenced by manipulation. So if somebody is somehow manipulated into consenting, if they are so maybe enticed by being paid or something like that, it's up for debate what counts as manipulation. But if it's manipulated or coerced, then that's not really voluntary consent. So coercion happens when it's the intentional use of credible and severe threat of harm to control somebody else. So if you force somebody to sign a paper, they're not really consenting to it. It's not voluntary consent. And manipulation is non-coercive ways of controlling a person's actions. Now, there might be certain forms of manipulation or subtle manipulation that are okay, like certain kinds of nudges. Nudging is a big thing that people talk about, and that might be okay. So if in the physician's office they have posters of nutritional information that might nudge somebody to eat healthier, that's not really manipulation, that's more nudging, so that's okay. But one example of manipulation would be, say, giving false information. Right. So that does it for this lecture. We talked about um, surrogate decision making. How do you make decisions on behalf of somebody who lacks decision making capacity or who lacks competency? We saw that the surrogate is usually somebody who's close to the patient, that knows the patient, and we use the principle of substituted judgment to make decisions for the person. And then we looked at informed consent and what goes into informed consent. That does it for this lecture.